Imagine trying to restore a completely clear-cut forest. But the catch is, the only timber you're allowed to use has to be dug up, root and all, from this tiny strip of land at the back of the property.
Right, and if you damage a single root during the relocation, that tree just dies.
Exactly. I mean, that is the exact mathematical and biological tightrope of modern hair transplantation. We have moved so far beyond that primitive plug era of decades past. We're operating in the era of microscopic follicular unit transplantation now,
Yeah.
manipulating anatomy at a level that, really demands absolute surgical discipline.
Oh, absolutely. The precision required today is honestly staggering. You're balancing this finite biological resource against progressive anatomical loss. It's a highly refined surgical art, and frankly, there is zero room for amateur hour in the OR.
Yeah, which perfectly sets up our mission for today. This deep dive into the clinical data is essentially a masterclass on modern hair transplantation. And it's designed specifically for you, the plastic surgery resident or attending. We're going to unpack the entire workflow from a highly clinical perspective.
Yeah, we're covering the physiological warfare of donor extraction, the ischemia clock that basically dictates your graft survival, aesthetic hairline architecture,
And managing those really complex reconstructive cases where the vascular supply is already working against you, right?
Exactly. Because identifying a good candidate is where the real surgery begins. Before a scalpel ever touches the scalp, a successful outcome is totally dictated by precise physiological preparation.
Right. So evaluating the donor area is a step one. And I see a lot of experienced surgeons who think they can just rely on the naked eye to assess donor density. But we are seeing a massive, necessary shift toward quantitative diagnostic tools like the foloscope.
Oh, you have to. You can't just eyeball it anymore.
No, you can't. I look at it like a non-renewable trust fund. You simply cannot afford to miscalculate the initial biological balance by just guessing.
Yeah, you really can't afford a rounding error when the supply is capped for life. The foloscope gives us hard, objective math. It captures images at 50-fold magnification, calculating density, caliber, and growth rate within a very specific fraction of a square centimeter.
Which is incredible data to have.
It is, and here's the key point. You use it to aggressively rule out poor candidates. I mean, if a patient presents with more than 20% miniaturized hairs in their donor area, they're entirely off the table for surgery.
Yeah, that has to be a hard clinical stop.
It is, provided you actually take the measurements properly. You need 2 separate sessions a few weeks apart to confirm the pathophysiology, because you have to differentiate between a follicle that is truly miniaturized due to androgenetic alopecia and a completely healthy follicle that just happens to be an early anagen.
Right, presenting with that thin, tapered edge protruding from the skin.
Exactly. You don't want to turn away a good candidate because of a misread on the hair cycle.
So once they clear that mathematical hurdle, you really have to manage their expectations with the consent conversation. There are 3 specific preoperative caveats you must hammer home.
Yeah, patients need to know what they're actually signing up for.
Right. First, severe postoperative edema. I mean, it's minimal for the vast majority, but about 2% of your patients are going to develop significant periorbital ecchymosis. They end up looking like they went a few rounds in a boxing ring.
They really do. It's jarring if they aren't expecting it.
Second is scalp hypoesthesia. We are physically severing sensory nerves during the harvest and recipient site creation. You need to tell them to expect numbness, and that those neural pathways take anywhere from 3 to 18 months to fully resolve.
Yeah, and the third caveat is the one that definitely causes the most post-op panic calls. Telogen effluvium, temporary shock loss.
Oh, yeah. The phone calls on that one are rough.
They are. The physiological trauma of the surgery basically forces surrounding native hairs into a premature resting phase. And this hits 10 to 20% of men and a staggering 40 to 50% of women.
Wow, half of female patients.
Yeah, up to half. So in real life, if you're evaluating a patient and they lack the emotional resilience to handle looking significantly worse before they look better, do not operate.
That is fantastic advice. Let's get into the pre-op regimen, because you have to ensure the surgical field itself isn't going to turn against you, right?
Yeah.
We stop vitamin E and fish oil 3 weeks out, and acetylsalicylic acid 10 days out.
Crucial step. If you skip that, you're in for a bad time.
Exactly. In real life, if a patient hides their fish oil habit, you're going to be fighting microscopic platelet inhibition all morning. You completely lose the pristine hemostasis required for recipient site visibility. We also start topical minoxidil, 2 to 5% a week prior.
Right, and the physiological goal with the minoxidil is actively prolonging the anagen phase. You are theoretically bolstering those native follicles to resist the surgical trauma that triggers the telogen effluvium we just discussed.
Makes total sense.
Yeah. And from there, we move to the day of surgery. So for anesthesia, we really rely on a field block inferior to the donor region. You initiate with 1% lidocaine with epi, 1 to 100,000 to secure immediate hemostasis and local control.
Right, get that vasoconstriction going.
Exactly. Then you follow that up with a longer-acting bupivacaine, 0.25 to 0.5%, also with epi. That ring block effectively knocks out the greater and lesser occipital nerves alongside the postauricular nerve.
Here is a massive clinical pearl regarding that field preparation for everyone listening. Do not just rely on the anesthetic for your tissue plane. You want to use sterile saline tumescence injected into the deeper subcutaneous plane.
Oh, absolutely. The tumescence is a game changer.
It really is. You're basically creating a hydraulic lift. You want to physically separate the follicle bulbs from the underlying nerve and vascular plexus. It makes the actual excision much easier, radically improves your hemostasis, and drops your follicle transection rate down to almost nothing.
So true. So the field is prepped, the tissue is tumesced, and you're ready for extraction. And the extraction method dictates not only the workflow for the next 8 hours, but the structural integrity of the patient's scalp for the rest of their life.
Yeah, so let's break down the methods. Strip excision remains the undisputed heavyweight, right? It accounts for about 88.5% of all cases. You harvest exclusively from the safe donor area. The ideal strip width is 0.8 to 1.2 centimeters.
Right, but the major surgical trap here is tension. Excessive tension causes localized ischemia, massive postoperative effluvium, or just wide, unsightly cicatricial scars.
Yeah, tension management is really what separates the technicians from the artists. Over the mastoid region, where tension is anatomically the highest, you have to use wedge-shaped sutures to distribute the force.
It all comes down to basic physics, doesn't it?
Completely. The mechanical work required to pull the wound edges together decreases as the angle of your suture placement widens along the superior edge. You are fundamentally easing the mechanical burden on the local vascular supply.
And you also utilize a trichophytic closure, right?
Yeah, exactly. You deliberately excise 1 millimeter of epidermis from one wound edge. This allows a row of hairs to literally grow right through the resulting linear scar, rendering it virtually imperceptible.
Such an elegant solution.
It is, and an absolute rule of thumb for secondary surgeries. Always include old scars in your new strip harvest. Virgin tissue surrounding a new wound ensures robust vascular and lymphatic supply.
Right, you don't want to isolate a strip of skin between two scars.
Exactly. If you leave an old scar lying superior to a new harvest line, you completely compromise lymphatic drainage and guarantee a nightmare of prolonged edema for the patient.
Well, that mechanical burden brings up a huge debate in the field right now. I mean, patients walk into the clinic demanding follicular unit extraction, or FUE, because they are terrified of the linear scar.
They all want FUE now, thanks social media.
Seriously. So with FUE, we bypass the strip entirely and punch out individual units. And punch size matters immensely here. A 1 millimeter punch yields about 2.5 hairs per graft, carrying a 2 to 8.5% transection rate.
Which was pretty significant.
Yeah, and if you drop down to a 0.75 millimeter punch to minimize the dot scars, your yield drops to 2.1 hairs and your transection rate creeps up to 3 to 10%.
Okay, I have to push back on the FUE hype here. If it leaves no visible line, and patients are practically begging for it, why does strip excision still dominate nearly 90% of the market?
Because you just cannot cheat the long-term math of the safe donor area. With FUE, you can only extract every third or fourth follicular unit without creating visible bald patches.
Right.
Even worse, FUE punch sites heal by secondary intention. The surface area of the scalp does not physically shrink the way it does when you cleanly suture a strip closure together.
So the absolute density drops permanently.
Exactly.
Let me use an analogy here because I think this makes it so clear. Strip excision is like clear-cutting a tightly defined single acre of timber. You take exactly what you need, pull the remaining borders of the forest together, and the rest of the land remains untouched and incredibly dense.
Right.
But FUE is selectively thinning the entire forest. You take a tree here, a tree there. Eventually, the whole forest looks sparse. You are permanently reducing the absolute number of viable follicles in that safe zone.
Yeah, and when that patient eventually loses their native fringe hair a decade down the line, that surgically thinned FUE donor area is going to look incredibly transparent and unnatural.
It's a real delayed consequence.
It is. That's why combining the two modalities is often the most sound long-term strategy. You maximize your absolute graft yield with multiple strip harvests over the years, preserving the density, and you only deploy FUE for a final cleanup session when scalp laxity is entirely depleted.
That makes a lot of sense. Now, whether you harvest by strip or FUE, the moment those follicles leave the body, the ischemia clock starts ticking loudly. Graft survival drops roughly 1% for every single hour the tissue spends out of the scalp.
Yeah, you're fighting ischemia-induced hypoxemia and rapid ATP depletion. It's a race. We combat that through highly regimented microscopic graft preparation.
Right, so for strip harvests, you utilize the slivering process. Your technicians slice the donor strip into these tiny sections just 1 or 2 follicular units wide under 6 times magnification with strong backlighting.
The skill of a good tech team is unbelievable.
Oh, it really is. It requires incredible dexterity, angling the blade perfectly parallel to the follicles to prevent transection. The structural goal of slivering is creating a pear-shaped graft.
Right, that pear shape is vital.
It is. You deliberately leave a protective envelope of dermis and subcutaneous adipose tissue around the follicle, the sebaceous glands, and the domal papilla. That adipose tissue is a biological shield against desiccation, which is the primary killer of out-of-body grafts.
Which perfectly highlights the main structural vulnerability of FUE grafts. Because they're pulled directly from their native environment using a tight cylindrical punch, they frequently lack this protective pear-shaped tissue envelope.
They're naked, basically.
Yeah, that vital surrounding domus gets stripped off during the mechanical extraction.
It's deeply ironic. Patients demand FUE, but the grafts themselves are fundamentally more fragile. I mean, compare a strip-harvested graft to transplanting a massive oak tree with its entire root ball and surrounding soil completely intact.
Right, a safe transfer.
Exactly.
Yeah.
But FUE is like yanking that same tree out of the ground with bare roots. But without that adipose shield, they're incredibly vulnerable to microtrauma, handling forces, and temperature shifts.
Yeah, and that fragility is exactly why our holding solutions are critical. We use chilled normal saline, intravenous fluids like lactated ringers, or advanced hypothermic tissue holding solutions like hypothermosol to slow that cellular metabolism to an absolute crawl.
Okay, so we have viable, metabolically protected grafts ready for implantation. Now, surgical precision must give way to aesthetic architecture. Let's look at the recipient's site.
This is why the artistry really happens.
Absolutely. The most anterior midline point of the hairline should sit exactly where the vertical plane of the forehead transitions to the horizontal plane of the anterior scalp. And when you view your patient laterally, that hairline needs to be roughly horizontal to the ground or tilting slightly superiorly.
Yeah, and the most common pitfall I see is surgeons advancing the temporal points too far anteriorly in young males. I mean, androgenetic alopecia is relentlessly progressive.
It never stops.
No, it doesn't. If you build a highly advanced, dense temporal point today, and the patient's native posterior hair recedes over the next 10 years, you leave them with unnatural, isolated islands of transplanted hair sitting stranded in the middle of a bald scalp.
Oh, the island effect. It looks terrible. You also have to adapt that hairline architecture to the patient's ethnic variations and skull shape. In Caucasian patients, you're typically working with a dolichocephalic or ovoid skull shape.
Right. Contrast that physiological canvas with East Asian patients. They generally present with a brachycephalic or rounded skull that inherently requires a wider, flatter hairline design.
Changes the whole approach.
It does. Furthermore, East Asian hair possesses a very coarse caliber. So if you place multi-hair grafts right on the anterior hairline, it looks incredibly harsh and pluggy. You are literally forced to use single hair grafts meticulously placed anteriorly to camouflage that coarse texture.
Now, patients of African descent present a completely different clinical advantage. They typically have a mesocephalic skull shape, allowing for a quite flat hairline. But the real physiological benefit here is the low color contrast between the hair and the scalp, combined with the tight, natural curl.
The illusion of density is amazing.
It's unparalleled. You can actually place multi-hair units much closer to the frontal zone without them looking artificial at all.
Yeah. And let's talk about the incisions really quickly. You see junior guys confusing angle and direction all the time.
Oh, constantly.
They'll get the direction right, which is simply where the hair points to match the natural whirl, but they will elevate the angle, the degree of elevation from the scalp, way too high. The patient ends up with a stiff cowlick that defies gravity, looking like a doll's head.
Right. And speaking of junior guys, the junior residents always ask a logistical question here. If a patient is paying for thick hair, why not just densely pack every single patient? I'm talking about forcing greater than 30 follicular units per square centimeter to build an absolute wall of hair.
Well, because you cannot outsmart the hard physiological limits of local vascular perfusion. Dense packing looks incredible on the table, I'll admit, but it risks severe vascular compromise and necrosis.
The blood supply just can't handle it.
Exactly. To fit that many grafts into tiny, tightly packed incisions, you have to heavily trim them down to a skeletonized state. You are removing that protective adipose shield we just talked about, making them highly prone to insertion trauma and desiccation.
Yeah, so if you are going to attempt high-density packing, you absolutely must use the stick-in-place method. You make the incision with your blade and immediately drop the graft into the site before moving to the next.
It's tedious but necessary.
Very. It minimizes microscopic bleeding and completely nullifies scalp recoil time. That means you can use physically smaller incisions and inflict less total vascular trauma, though, as you said, it is incredibly labor-intensive for the surgeon.
Yeah. And even a flawlessly executed primary surgery can be totally undermined by the progressive nature of hair loss or severely complicated by prior surgical trauma. We have to discuss reconstructive challenges and perioperative adjuncts.
Absolutely. Medical management is your first line of defense to protect your surgical results. Finasteride, 1 milligram daily, slows hair loss in roughly 87% of patients. But you have to have a very blunt conversation about this systemic profile.
You really do.
Patients must be warned about recent accusations linking finasteride to high-grade prostate cancer, depression, and permanent sexual side effects.
Yeah, and you also must explicitly warn them that finasteride artificially lowers prostate-specific antigen values. Their urologist needs to know they are actively taking a 5-alpha reductase inhibitor so they can adjust the PSA baseline accordingly.
Right, otherwise you entirely mask a rising PSA.
Exactly, which is incredibly dangerous.
Let's shift to a reconstructive scenario you will actually see in real life. Facelift adjuncts. A patient comes in with stark petrichial or poststructural scars from a previous facelift, or, their temporal sideburn was displaced superiorly during the lift. Hair transplants are an excellent camouflage tool here.
There are, but you are dealing with cicatricial alopecia, dense scar tissue. Here is your critical surgical pearl. Do not use epinephrine in your local anesthetic when working in these specific zones.
Yes, sir.
The vascular supply is already heavily compromised by the fibrosis. Epinephrine induces severe local vasoconstriction, and without robust collateral flow, you will outright lose the grafts.
You also have to drop your implantation density way down. Aim for a maximum of 15 to 20 follicular units per square centimeter. If you try to densely pack a scar, you'll completely overwhelm whatever microscopic neoangiogenesis is present, and the entire reconstructed zone will necrose.
Yeah, you have to respect the tissue. We also handle a massive volume of corrective surgery for old, pluggy transplants from the 80s and 90s. You can't simply pack new, refined hair around large, unnatural plugs and hope it blends into a natural gradient.
No, it just looks like a grassy knoll.
Right. You have to physically remove the offending architecture.
Yeah, so you take a 1.5 to 2 millimeter punch and partially excise the old plug. You must core deep enough to hit the subpapillary adipose tissue. If you stay too superficial, the transected plug will simply grow right back through the star.
And then you're back to square one.
Exactly.
Yep.
Once you extract it, you dissect those coarse hairs under the microscope and recycle them into smaller, natural follicular units.
Yeah, and the counterintuitive part of plug correction is the wound care. You must leave those punch sites completely open to heal by secondary intention. Do not suture them closed.
Which feels wrong as a surgeon, but it's essential.
It is. Suturing creates localized mechanical tension, which chokes off the regional blood flow and will reliably kill any new microscopic grafts you place nearby to soften the hairline.
All right, I want to bring up the toughest consultation you will ever face. We have all been there. A 19-year-old male walks into your clinic.
Oh boy, here we go.
Yep. He has minor temporal recession, but a severe family history of baldness. He demands a low, dense teenage hairline, and he has the money ready to go. How do you handle this aggressive demand? In real life, it happens constantly.
It does.
You can't treat this like a simple aesthetic request, right? Like correcting a mild tosses of the eyelid. The long-term stakes are a completely different animal.
Yeah, that is where you have to take off your surgeon hat and put on your psychiatrist hat. You firmly explain the biological math, and you virtually never comply with the request.
Never.
We rely on the Hamilton-Norwood scale to project the future. If you project that this 19-year-old is genetically destined to evolve into a type 6 male pattern baldness, his lifetime donor yield is strictly capped. Assuming average density, his absolute lifetime harvest limit might be roughly 5,400 follicular units.
Which sounds like a lot until you start doing the math. If you blow 3,000 of those precious grafts rebuilding a flat, low teenage hairline today, and he inevitably loses all his mid-scalp and crown hair by age 30, he is completely out of ammunition.
Yeah, he's stuck.
He will have a dense frontal band, a massive, shiny, bald void right behind it, and zero donor hair left to harvest. You have basically facilitated a permanent anatomical disaster.
Exactly. You keep the threshold for surgical eligibility extremely high for young patients. You put them on aggressive medical adjuncts to stabilize the loss. You design a mature, age-appropriate hairline that will stand alone naturally when the native hair behind it eventually falls out. And you conserve their donor supply at all costs.
Perfect. Let's bring this all together with a quick surgeon-to-surgeon recap of the core takeaways from the clinical data.
Sure. Respect the unforgiving math of the safe donor area. Your grafts are finite, so protect them from transection and excessive tension. Minimize out-of-body ischemia by handling the tissue microscopically, maintaining the adipose shield, and getting it back into a vascularized bed immediately.
Right.
And finally, ensure your architectural design accounts for the patient's long-term physiology and ethnic phenotype. You are planning for the patient's scalp at age 60, not just age 25.
Yeah, it all comes down to aggressively managing biological limits. Which brings me to a final thought for you to chew on before your next case. The entire foundation of everything we discussed today, the tension sutures, the ischemia clocks, the Norwood projections, it's all based on the concept of absolute scarcity.
Right, the donor area is finite.
Exactly. The safe donor area is severely limited. But look at the horizon of cell therapy. We are seeing early, aggressive research, isolating stem cell-rich mesenchymal cells directly from the dermal papilla, propagating them in vitro, and inducing completely new follicle growth.
It's fascinating stuff.
It is. Right now it's experimental. But ask yourself, what happens to the field of plastic surgery and all the surgical techniques we rely on today when the strict mathematical limits of the donor area suddenly disappear completely? If hair is no longer a finite trust fund, but an entirely unlimited resource, how does that fundamentally rewrite the rules of aesthetic reconstruction?